Pues nada, buenos días, muchas gracias por vuestra presencia, o los que estéis conectados online. Mi nombre es Enrique Marco, yo soy radiólogo, me dedico a la neuroradiología, como algunos sabréis. Aquí estoy con Sofía Bretos, que es una de nuestras residentes, que tiene el placer tenemos hoy el placer de tener aquí al doctor Robles, que le conoce mucho más Sofía, así que le voy a presentar más ella.
Bueno, buenos días a todos, gracias por venir. Me hace especial ilusión presentaros al doctor Robles, que además de ser mi padrino, es neuroradiólogo en la clínica MAYO. Él hizo la residencia en el Walter Reed, que me cuesta mucho pronunciar, de Washington, el fellow en neuroradiología en la Johns Hopkins, donde es también profesor, y desde hace 22 años es neuroradiólogo en la clínica MAYO. Entonces, me faltan cosas por decir seguro. Es profesor en la Universidad de Navarra también, profesor en la Facultad de Miami, en la Johns Hopkins y también en la clínica MAYO. Y nada, cuando quieras, Héctor.
Buenos días. Antes que nada, quiero darle las gracias por el privilegio de estar aquí y que tengo que disculparme porque la conferencia es en inglés, que es mi lenguaje profesional. Así que voy a tratar de cubrir la conferencia en 45 minutos, por lo general me tomo un poquito más de eso, pero vamos a empezar. We are going to be talking about brain tumors today, and typically the approach of brain tumors. The objective is essentially to have a brief overview of the brain tumors and a practical approach to the differential diagnosis. There are fundamental questions that we ask ourselves when we are studying brain tumors, essentially. Number one, we ask about our age. We ask about whether it is intraaxial versus extraaxial. We ask about the location of the tumor to see whether it is infratentorial, supratentorial, whether it is deep within the brain substance or peripherally, or is it intraventricular, which is classified as extraaxial. We also think about the pattern of enhancement of the tumor. Is it enhancing, yes or no? Is it solid enhancement or is it peripheral enhancement? Is it thin enhancement, thick or nodular enhancement? On CT, we ask the questions about the density of the tumor. Is it hyperdense or hypodense? Or does it have a density that is like the CSF? We also ask whether there is calcification, hemorrhage within the tumor. On MRI, we ask, does the tumor have restricted diffusion? And in the perfusion images, is it hyperperfused or hypoperfused? And both on CT and MRI, we ask, is there evidence of necrosis? Are there any cysts or nodules? In the infratentorial neoplasms, we will start looking at those. First of all, the extraaxial tumors. The nerve sheath tumors, including schwannoma, we also have meningioma, epidermoid. We also include here arachnoid cyst, even though it's not technically a tumor. Others we have lipoma, dermoid, and subarachnoid seeding by tumor. So essentially we're trying to classify these tumors and how to approach them when we are looking at an image. The first case is going to be a vestibular schwannoma. You see here that there is a focus of hyperintensity here. It's actually enhancement within the internal auditory canal in the left side. That is an intracanalicular schwannoma. Also, you can see it on, this is called axial ultra high resolution T2 weighted image, pretty much. Some people call this a KISS sequence, so sometimes it's called space T2, which demonstrates this nodule that has hypointensity. This is a little bit more obvious case. As you can see, bilateral vestibular schwannomas, meningioma, And also we can see here another tumor, which is it's going to be either a meningioma or another schwannoma, which is a case of neurofibromatosis type 2. And also we can see very faintly here that there's another tumor in the ependyma here, which is an ependymoma. This is a typical case of neurofibromatosis type 2. Here we have an example of the bilateral schwannomas, the either meningioma or schwannoma of the bilateral cavernous sinus regions or Meckel cave region. Also we have meningiomas here in the convexity and in the falx cerebri. And notice this particular tumor, even though it is slightly extending into the internal auditory canal in the left side, it has a broad base attachment to the dura and a dural tail of enhancement that is typical for a meningioma. Now, notice also here that on T2 wetted images, it is hypo-intense. Typically, schwannomas you would expect to be more hyper-intense on T2 wetted images. So these are indications that this is actually a meningioma. In this particular tumor, you can see that there is, on T1 wetted images, there is a relative hypointensity that is somewhat similar to the water, but not exactly the same. But when you do a FLAIR images, you will see that there is some heterogeneity in the signal intensity, and there is restricted diffusion, which is the hallmark of an epidermoid. And lastly here, you can see that there is a focus of low signal on T1. It follows the signal of water on all sequences, and it does not restrict diffusion. This is a typical appearance for a arachnoid cyst. So, in the infratentorial tumors, we go into the intraaxial tumors. In children and young adults, the most significant would be medulloblastoma, juvenile pilocytic astrocytoma, and the brain stem, which is typically a fibrillary astrocytoma, or they have reclassified the astrocytomas in general like a diffuse astrocytomas. In adults, we think about infratentorial intraaxial tumors like metastatic disease and hemangioblastoma. First of all, let's look at the first one down here, medulloblastoma. It is centrally located. There is some heterogeneity in the signal intensity within it. It may actually extend into the fourth ventricle from the vermis, for example. The next tumor you will see here is sometimes typically seen as a cyst with a mural nodule down here. This happens to be peripherally enhancing, hyperintensity on FLAIR, peripheral enhancement on the postcarolinum. And this is a pilocytic astrocytoma. Pilocytic astrocytomas, typical description, cyst with a mural nodule, but they can be also solid tumors as well. This is a more typical appearance of a pilocytic astrocytoma, cyst with a mural nodule. And when I was a disciple of Jean Smirnotopoulos, and he said that if you resected the enhancing portions of the tumor, you would essentially cure the patient. Compare this intraaxial tumor to this one down here. This is a diffuse astrocytoma or fibrillary astrocytoma. It is actually intraaxial. It is the pattern of growth. It is instead of being expansal, it's more infiltrative pattern of enhancement, has mass effect upon the fourth ventricle and can produce hydrocephalus. Now, the fibrillary astrocytomas are a WHO grade 2 tumors, but 50 to 60% of them may have anaplasia, a third of them may have enhancement, and 25% of them may have a 10-year survival. The reason is because even though you may have a relatively low-grade astrocytoma, it is in a malignant location. This one down here is a patient with von Hippel-Lindau syndrome, has multiple hemangioblastomas. They look like Christmas tree ornaments down here. Intensely enhancement, nodules. They can be nodular or they can be cysts with neural nodules. So the hemangioblastomas from the imaging standpoint are indistinguishable from the pilocytic astrocytomas and other ones that we will be talking shortly. If you go into the infratentorial intraventricular tumors, remember the intraventricular tumors are also classified as extraaxial tumors. You think about ependymoma, subependymoma, and choroid plexus papilloma. Now, if you think about it, is what lives there? You will have ependymal cells, and we can give you those tumors, and you can also have the choroid plexus. Another one that is not mentioned there, you can potentially have a meningioma that typically intraventricular meningiomas tend to be in the atrium of the lateral ventricle. An example here of an ependymoma has relatively iso to low signal in relation to the cortex on T1 weighted images, but when you give contrast, it acquires this fairly solid enhancement. But you see that there is some conformity of the shape of the fourth ventricle, and it actually fills the fourth ventricle, and it actually can insinuate into the foramina of Luschka and Magendie. Now, they call this a socoplastic ependymoma because he has the plasticity of deforming the area without essentially destroying it. How about the supratentorial tumors? Extraaxially, we have the meningioma, most common, but you can also have arachnoid cysts, germ cell tumors, so-called pinealomas, dermoids, lipomas. You can also have subarachnoid seeding or leptomeningeal metastatic disease, and you also have the craniopharyngioma. We have an example here of a plenum sphenoidale meningioma. You know that this is an extraaxial mass lesion because, number one, it is crossing the midline. Number two, you can see that the cortex is actually draping around it. And sometimes you can see a little bit of a cleft of CSF next to it. And it's a typical location. It's a very vascular tumor, and is homogeneously enhancing and has associated areas of surrounding vasogenic edema. We have an example here of a suprasellar meningioma. It has kind of like an intermediate signal intensity on T2 weighted images. It is hypo-intense or relatively hypo-intense or near iso-intense to the cortex on T1 weighted images without contrast. It has homogeneous enhancement, but notice here that there is a thin plane separating it from the pituitary. So it is extending into the diaphragma sella, but it's not extending inferiorly. You can also see that plane separating it from the pituitary down in this image. This is a patient that has this focus has CSF signal intensity on all sequences, which is located in a cavum velum interpositum, extraaxial space, but has a mass effect. This is a arachnoid cyst, and you know it is going to be an arachnoid cyst because it follows the signal intensity on all sequences. This is a very sad but interesting case here. If you look at it here, this happens to have a little bit of air down here in the frontal horse. Probably the patient had an LP or some other procedure, but you can see this extraaxial mass lesion in the pineal. There is a focus of calcification, which is the pineal calcification, and we have this expansile mass lesion. How do I define expansile versus infiltrative? Expansile mass lesion is when you have a lesion that grows like a sphere, the vector growth, as opposed to an infiltrative mass lesion, which is typically what you see spreading along the white matter tracts like a glioblastoma. You can see when you give contrast, this is a flare post-contrast, that there is some hyperintensity. There is, at that time, this enhancement, and 4 months later, you can see that has become a multicystic enhancing expansile type lesion. Patient with a yolk sac tumor. This is a patient who has a hypothalamic lipoma. It has fat signal intensity on all sequences, and if it is large enough, you might be able to see some chemical shift artifact. Important thing to remember is that this patient does not have a tumor, it is a malformation. This doesn't grow, so it doesn't necessarily need to be followed. Lipoma here essentially in the hypothalamic region. Now this is an interesting case here. Patient has a flare sequence post-contrast. You can see that in the center of the flare image, it has the expected location of water, which is dark. However, all the CSF spaces, subarachnoid spaces, are enhancing and makes it look like a T2 weighted image. The reason for that is because this is all enhancing tumor in a post-contrast flare study, and this is essentially an area that has not been invaded by tumor. Now, if you look at the cord here, you can see that there is a thin line of enhancement surrounding the cord. This is subarachnoid seeding by tumor in a pattern that at the FIP there was described as sugar goose or sugar ice pattern, because instead of having tiny nodules attached, there is a whole coating of tumor surrounding the cord, which is a similar effect that you're seeing down here in the brain. Subarachnoid seeding by medulloblastoma. Another finding that you can have identical imaging findings is going to be a patient that have sarcoidosis, neurosarcoidosis. In neurosarcoidosis, we have a granulomatous inflammatory process that can be in the leptomeningeal surfaces, and it burrows through, gets into the perivascular spaces, secondarily invading the brain, and it could also have associated subcortical white matter, areas of infarction, ischemia, etc., that can give you the signal abnormality in the white matter as well. We have a case here of craniopharyngioma, another, this happens to be a supratentorial extraaxial tumor. It is the so-called motor oil type tumor. There is a mixed cystic and solid tumor with a layering debris that you can see down here and also on coronal images. So if you think about mnemonics, is how to remember differential diagnosis to have in your mind. Essentially, you can have cortical or subcortical metastatic disease, hemangioblastomas, astrocytomas, oligodendrogliomas, neuroblastomas, gangliogliomas, ependymomas, and pleomorphic xanthosarcomas, about intraaxial peripheral cortical tumors. In other words, we are now into the intraaxial tumors, supratentorial, that are peripherally located. In this slide, we see a subependymoma. An ependymoma, I meant to say. It is a tumor that has associated areas of calcification. It is very peripherally located, cortical, subcortical. And in looking at this one here, you may tend to think, are we dealing with a meningioma that has burrowed through, which is in the differential diagnosis down here? This happened to be an ependymoma. And again, it's one of those tumors that has a high nuclear to cytoplasmic ratio and can have associated areas of hyperdensity in addition to the possibility of being calcified. Another thing about ependymomas is that when you have supratentorial ependymomas, they have a tendency to be outside the ventricles, even though they may or may not have a connection to the ventricle itself. The next slide here, we have an infiltrative mass lesion. There are some areas of signal intensity heterogeneity that might correspond to areas of calcification. You can see some areas of calcification here. It extends into the cortex down here. It is located in the frontal lobe, this one particularly. This is a typical location and appearance for an oligodendroglioma. And an oligodendroglioma, they think about other, with the newer classification of tumors, they include the pathologic findings, or whether it's Q deletions, etc., that are part of their diagnostic from the pathologic standpoint. Another example here of an oligodendroglioma, we have areas of calcification. We have this tumor that is kind of a lower attenuation. It is superficially located, extends into the cortex, and because these are slow-growing neoplasms, they may have associated remodeling or scalloping of the overlying calvarium. And they may have mild or no enhancement. I mean, there is variable enhancement. So, if you take a look at oligodendrogliomas tend to be in the 5th or the 6th decade of life. They calcified in 80 to 90% of the cases. They're slow growing. It involves the cortex and has either mild or no enhancement and may scallop or remodel the calvarium. Male to female ratio is 2 to 1. Gangliogliomas. Gangliogliomas is another cyst with a mural nodule that it is intraaxial. Indistinguishable, we already talked about another cyst with a mural nodule, which is going to be the pilocytic astrocytomas. We also mentioned about the hemangioblastomas, which can be cysts with a mural nodule. So these are 3 so far in the differential diagnosis. Ganglioglioma. And these tend to be superficially located as well. Another example of a ganglioglioma with a cyst with a mural nodule. Gangliogliomas, 60 to 80% of them present before the age of 30. It is the most common mixed glial neuronal tumor of the CNS. It is a low-grade tumor, solid, cystic, and or calcification. They present with seizures. They have a feeble predominance, and typically it is in the temporal lobe, 85% of the cases, but it can be also in the frontal lobes and the anterior third ventricle, and may have associated bone remodeling. This is a case of a pilocytic astrocytoma, which is again indistinguishable from a ganglioglioma, indistinguishable from a hemangioblastoma. The pilocytic is a grade 1 tumor. And another one that has a similar appearance is going to be the pleomorphic xanthoastrocytoma, cyst with a mural nodule superficially located, and this happens to be more like a children tumor. So you're considering the age of the patient, the location of the tumor, whether it is intraaxial or extraaxial, whether it is superficial or deep, and the appearance, cyst with a mural nodule or calcification. Okay. How about supratentorial tumors that are intraaxial and are deep? You think about primary CNS tumors, like glioblastoma, is not multiforme anymore. Also, diffuse astrocytomas, lymphoma, primary CNS lymphoma, metastatic disease. Remember that metastatic disease can be deep, even though they are typically subcortical or PO as well, and they can be deep as well. This is an example of a glioblastoma. You can see it is an infiltrative mass. Lesion has heterogeneous signal with hyperintensity on flare down here, and has areas of hemorrhagic component, and has areas of heterogeneous enhancement, and importantly is one of the tumors that cross the midline. If you think about tumors that cross the midline, glioblastoma, lymphoma, and other types of astrocytomas. Also, you can have inflammatory processes like toxoplasmosis and demyelinating processes that can cross the midline as well. Glioblastoma is 15% of all intracranial tumors, is nearly half of all astrocytomas. There's a slight male predominance. Location is typically frontal, greater than temporal, but again, it is everywhere. It can be in the cerebellum, it can be in the brain stem, it can be in all any areas. It can produce a so-called butterfly pattern, which is if you have microscopic multifocal connection, multifocal if it is microscopic connection, or multicentric if there's no detectable microscopic connection. Glioblastoma, here we have these flame shape, if I may, or butterfly type gliomas that is crossing the midline. So How about intraventricular tumors that are either cystic or intraventricular tumors that are supra or infratentorial? We have the colloid cyst, which is an inclusion cyst, central neurocytoma, ependymoma, subependymal giant cell astrocytoma, also chorioplexus papilloma, carcinoma. You can also have meningiomas inside the ventricles and metastatic disease. This is a patient that has an anaplastic ependymoma. There is an extraaxial mass lesion which is intraventricular, has heterogeneous enhancement, has entrapment of the temporal horn in the left side. This is an example of a subependymoma that has a spherical or expansal growth, has associated heterogeneous enhancement, and has hydrocephalus. And we have the central neurocytoma here, heterogeneous lesion down here. There are some areas of multiple cysts, small cysts within it. Typically originates from the septum pellucidum, but can also originate from the ependyma. Central neurocytoma, it typically occurs in 20 to 30-year-old. Previously may have been diagnosed as central neuroblastomas and oligodendrogliomas. Calcification is seen in 70% of the cases. There's variable enhancement, and key point, aside from the location, is that there are small cysts in 60 to 70% of the cases. This is a case of a choroid plexus tumor. Another intraventricular tumor. Here you can see that there is located within the atrium of the lateral ventricle, but has secondary invasion of the underlying brain parenchyma. Notice also that there is some entrapment or enlargement of the right temporal horn. However, all the ventricles are enlarged, and there is a reason for that, because choroid plexus tumors, because they produce CSF. As a result of that, you will have the effect of the obstruction from the tumor itself, but you also have the overproduction of the CSF, which can overcome the ability of the pachyunar granulations to absorb it. So you have components of obstruction and overproduction of CSF. Now, if the choroid plexus becomes a choroid plexus carcinoma, it might lose the ability to produce CSF, and you may not see the multiple, the panventricular enlargement. The next case here, we already looked at one of these cases, is a so-called plastic ependymoma. You can see that it conforms to the shape of the fourth ventricle and insinuates down below the foramina of Bluchka and Magendie. Example of an ependymoma, it's seen for the fourth ventricle, heterogeneous enhancement, may have some areas of calcifications. Some people compare it to toothpaste. This medulloblastoma, we looked at this case already, may have secondarily extended into the fourth ventricle. How about if we have on CT, hyperdense tumors on CT? You can have hyperdense tumors because high nuclear to cytoplasmic ratio due to high electron density, which may not necessarily be associated with calcification. If there's no calcification, if you have hyperdense tumors on CT, these high nuclear to cytoplasmic ratio tumors include extraaxially the germinomas and meningiomas. Intraaxially, you have the primitive neuroectodermal tumors, primary CNS lymphoma, and medulloblastoma. An example here of a desmoplastic medulloblastoma. Desmoplastic medulloblastoma is a variant of medulloblastoma that occurs in an older age group, in maybe mid-30s or so. Don't quote me on the age, but it tends to be more peripherally located than the typical medulloblastoma that you see in younger children. This particular has associated hyperdensity because high nuclear to cytoplasmic ratio. Secondarily has effacement of the fourth ventricle with obstructive hydrocephalus. Another high nuclear to cytoplasmic ratio hyperdense tumor is going to be the primary CNS lymphoma, intraaxial tumor. Here we have an example of a germinoma, extraaxial tumor, which is hyperdense because of high nuclear to cytoplasmic ratio. So how about if the hyperdensity on CT is due to calcification? If you have extraaxial tumors, think about subependymal giant cell astrocytoma, ependymoma, craniopharyngioma. You could also have osteomas extraaxially, and intraaxially you can have metastatic disease, particularly calcified metastatic disease. Think about the mucus producing tumors like adenocarcinomas, like breast, for example, or colon carcinoma can have calcifications. Also, oligodendrogliomas will have calcification, and ependymomas that we had seen before. An example of a craniopharyngioma, which has areas of calcification in addition to areas of intrinsic hyperdensity. A case here of a subependymal giant cell astrocytoma, which is a WHO grade 1 tumor. An example of an ependymoma has areas of calcification and areas of non-calcified hyperdensity because of a high nuclear to cytoplasmic ratio. An example of an oligodendroglioma with areas of calcification, again, frontal lobe superficially located extend to the cortex. And cavernous malformations. It's not really a tumor. It's actually a vascular malformation, slow flow, that has bled and produces these areas of hyperdensity, which may have associated calcification. And on MRI, you will see this called hemosiderin stain, which is a low signal intensity on all sequences, in addition to the central area of heterogeneous signal intensity. How about if you have the CSF-like density on CT? Extraaxially, we have arachnoid cyst, we looked at that, craniopharyngioma, because it has some areas of cystic components, epidermoid. Intraaxially, we have neuroepithelial cysts, pilocytic astrocytoma, because it has cyst with a mural nodule, ganglioglioma, because it has cyst with a mural nodule, and I will add to that pleomorphic xanthoastrocytoma and hemangioblastoma. An example of an arachnoid cyst, CSF density on CT, CSF density, signal intensity on MRI does not restrict diffusion. Neuroepithelial cyst, it is an expansile cystic collection down here that has associated deformity of the brain surrounding it. How about cysts with enhancing nodules? Pilocytic astrocytoma, hemangioblastoma, pleomorphic xanthoastrocytoma, and gangliogliomas. An example of a cyst with a mural nodule in a patient with pilocytic astrocytoma. Pilocytic astrocytoma, birth to 9 years of age, usually greater than 6 centimeters. Daughter cysts or nodules can be seen, can calcify in about 20% of the cases. The walls and the nodules may enhance, eccentric location in the cerebellum, and may be associated with polycythemia vera due to erythropoietin secretions, and may be associated rarely with a Turco syndrome. Example of, again, pilocytic astrocytoma, cyst with a mural nodule. Example of hemangioblastomas, we looked at this case already. Example of a pleomorphic xanthoastrocytoma in a child, again, this is one of those tumors that has a similar appearance to the pilocytic astrocytomas. How about if you have hemorrhage within the mass lesion? Favor metastatic disease. Typically, melanoma is a very vascular tumor which will have a propensity to bleed, the same thing as renal cell carcinoma, also breast and lung because they're so common, choriocarcinoma, and thyroid. They're very vascular tumors. If you have a small internal amounts of hemorrhage, think about a high-grade astrocytoma like glioblastoma. If you have that the whole mass is hemorrhagic, think about metastatic disease. So, the neoplastic, the hemorrhage that you see in a tumor, it has intermediate signal intensity. It does not follow the usual evolution pattern of a typical brain parenchymal bleed. There's a delayed temporal resolution. There is irregular, absent, or broken hemosiderin rings on T2 and susceptibility weighted image. There is persistent or increasing edema, which is a key factor where you have to get some follow-up studies. And obviously tend to be multiple lesions and disproportionate mass effect. if you have a hemorrhage within the tumor, you have in the differential diagnosis a pineal choriocarcinoma and teratocarcinoma, primary neuroblastoma, oligodendrogliomas, melanomas, also propensity to bleed, ependymomas can also have hemorrhage in 50% of the cases, glioblastoma, 35% of the cases, and other metastases like renal cell carcinoma, thyroid, choriocarcinoma, and also the common tumors like bronchogenic carcinoma or breast. This is a patient that has hemorrhagic metastatic lesions. This is what I mean by hollow hemorrhagic. The whole mass lesion is hemorrhagic, pretty much. This is a patient that has, with a glioblastoma, has small amounts of intracranial hemorrhage. How about necrosis? Necrosis, extraaxial mass lesions with necrosis, think about metastasis, so-called malignant meningioma and hemangiopericytoma. Intraaxially, think about glioblastoma, lymphoma, particularly in AIDS patient, anaplastic astrocytoma, metastatic disease, and a rare tumor called the atypical teratoid rhabdoid tumor. An example here of an atypical teratoid rhabdoid tumor is a very large tumor, irregularly marginated with heterogeneous enhancement with necrosis. Another example here of a rhabdoid tumor, again, similar features, you can see it on CT and on MRI. And this, another one, a typical teratoid rhabdoid tumor, very variable appearance. The atypical teratoid rhabdoid tumor of the infancy and childhood is a WHO grade 4, and you can see in younger age at 1.6 years of age. It occurs typically in the cerebellum, but also it can occur in the cerebrum and the pineal as well. Maybe indistinguishable from medulloblastoma, but the response from chemotherapy is poor. It can have hemorrhage, necrosis, or calcification. It has a thick, enhancing nodular rind. Now, the next case here is called a lymphoma. Lymphoma has a propensity to grow around the ependyma as well. Some people call it lymphoma, and has homogeneous enhancement. It has a relatively small amount of edema, of mass effect for the expectation that you would think about the tumor of this size. Another example of a lymphoma, and these, notice that they tend to have homogeneous enhancement, and they also have restricted diffusion because of the high nuclear to cytoplasmic ratio. There is a little extracellular space. So lymphoma is seen, primary CNS lymphoma is seen with increased incidence in the immunocompromised patients like transplant, but also in the HIV population. It's multifocal in 20 to 40% of the cases, more so in the HIV population. It is typically seen in the white matter, but also seen in the basal ganglia. How about the category when you have a non-enhancing tumor? In the extraaxial components, non-enhancing, you will include like cystic schwannoma. You can also have arachnoid cyst. You can have steroid suppression, epidermoid, and you can also have intraaxially the non-enhancing low-grade astrocytoma, oligodendrogliomas, and gangliogliomas can also have non-enhancement. An example here of a mixed oligoanthrocytoma that has a very minimal patchy, if any, enhancement. It is superficially located. Another example here of a relatively low-grade astrocytoma. It is infiltrative, has a tiny nodule of enhancement. So, how about the ADC, or essentially restricted diffusion? High at ADC implies a lower grade, low ADC, which means higher grade, that means restricted diffusion. And there's a lot of variability in high-grade tumors and necrosis, etc. It is an example of a glioblastoma that has associated restricted diffusion. And lymphoma typically has restricted diffusion. You can see the enhancing tumor, you see the areas of restricted diffusion here. This is an example here that has radiation necrosis produced they were irradiated vestibular schwannoma, and they produced radiation necrosis on the left aspect of the pons and the left middle cerebellar peduncle, which is another thing in this patient with neurofibromatosis type 2. Perfusion. You can have a perfusion, or you have increased or decreased CBV perfusion. Enhancement, just by looking at the enhancement, doesn't mean that you have increased perfusion. If you have increased CBV perfusion, that means that there's microvascular proliferation. There tends to be a higher grade tumor. When you have decreased CBV perfusion, you can have that, for example, in lower grade gliomas. It implies a lower grade tumor. And there is a high variability of high grade tumors to if they have necrosis, etc. This is an example here of increased CBV perfusion in this patient with glioblastoma. The pattern of enhancement, you can see that there's a little bit of enhancement, but there's actually some increased CBV perfusion in other areas that are not necessarily very enhancing. Calcifications. Neoplastic calcifications you can see in choroid plexus papilloma, ependymoma, dermoid, glioma, craniopharyngioma, meningioma, metastatic disease, especially osteosarcomas and mucinous carcinomas, oligodendrogliomas. You can also have in tuberous sclerosis, chronic hematomas, and old infarcts, like dystrophic calcifications. So the last slide here, in conclusion, intraaxial tumors tend to be dominated by glioblastoma, metastatic disease, and lower grade astrocytomas. Extraaxial tumors most commonly dominate meningiomas, schwannomas, arachnoid cysts, and epidermoid. Intraventricular meningioma, ependymoma, neurocytoma, and choroid plexus papilloma and cholexis. Those are the intraventricular tumors. Thank you for your kind attention. Okay. Any questions? Preguntas? Muchas gracias.